So we left off here. Remember, we have gone through the different kinds of joints that we find in the body. So we have talked about how we can classify our joints functionally based on how much movement they have. So remember, we have synarthroses, which are immovable, amphiarthroses, which are slightly movable, and diarthroses, which are freely movable. And then we also walked through some how we classify our joints structurally, so what's holding them together. So we talked about fibrous joints, cartilaginous joints, and lastly, synovial joints. We spent the most time on those synovial joints, talking about all the structures in the joint. We also talked about different kinds of motion that we can get out of our synovial joints, okay, based on the articulating bones. Another thing that I mentioned to you, remember, is that joints are the weakest part of the skeleton. We make them stronger by three different ways. One would be how well the bones fit together. Another one is the number, the different directions that they run. The most important is how tight your muscles are. All right. So we left off here talking about, we're going to walk through some selected synovial joints. This first one is the Temporomandibular Joint, which is basically where the mandible connects into the temporal bone. And so a lot of times we call this the TMJ joint. And this is basically a hinge joint. Again, think of a door hinge. So it allows your mandible to depress and elevate, right? That's important for chewing. So open and close your mouth. But it also allows for a little bit of lateral movement, right? You can move your jaw side to side. This is unique to certain mammals like humans and cows and horses. I have a friend who won't chew gum because she says it's too bovine, like it looks like a cow when you're chewing gum. And so that always reminds me of that, sort of that lateral movement of the jaw. Okay, so that's why we say it's a modified hinge joint. So I am going to actually show you a picture and I'll come right back. So you can see over here, the image on the top right, you can see this is the TMJ. So it is where, if we look over here, you can see it's where the mandible connects up here to the temporal bone. And if we actually look at that joint, you can see here, this is the mandibular fossa, and this is the mandibular condyle. Remember, condyle comes in contact. So those two come together. It is a shallow socket. So this is not a very deep, good fitting socket here. So a lot of times what we'll find are some imbalances with TMJ. It is very easy because of that shallow socket for that joint to dislocate. A lot of times it'll dislocate anteriorly, which means basically the entire mandible shifts forward to realign the joint. A lot of times you have to put your thumbs in the mouth and kind of push on the mandible and push it back into place. It is not uncommon for people when they have problems with that joint, if they open their mouth really wide, it can dislocate and their mouth is left open. They have to have it pushed back into place. Okay. There's also a lot of pain that can be associated with this joint, and the pain might be in your jaw. You might feel it in your ears. You might feel it in maybe in the muscles of your face on the side. A lot of times what causes the pain in this joint is either grinding your teeth, which a lot of us do at night, or sometimes you get muscle spasms. You have a muscle right here called the masseter muscle, and it helps you close your jaw. And so the treatment for this is a lot of times caused by stress. So reduce your stress. Massaging the muscle in here can help. Taking muscle relaxants can help as well. I started getting, I had some pain. It started about 2 years ago, and I went to the dentist positive that I had to have a root canal. I've never had a root canal, but I knew my teeth hurt so bad. And I went in, and he used that metal thing and he tapped on my teeth and I had no pain. And he's like, huh, And then he took his fingers and just pushed on my masseter muscle on the side, and I went, "Whoo!" And it hurt so bad. And he said that I'm probably just clenching my jaw when I sleep at night. And so gave me some different things to try to alleviate that. So it's super common. So you can see again, there's that TMJ joint. Okay, so again, that's a synovial joint. We're just walking through a few synovial joints. Now we're going to move down into the shoulders. We'll talk about those as well. Now your shoulders are different. These are actually a ball and socket joint. And the socket, remember the glenoid cavity? It is a relatively shallow socket. But this is actually good for the shoulder because it gives you a greater range of motion. But it also means that it's less stable. So, you know, I have right here, think of a golf ball on a tee, right? You know, it's not very stable sitting on that little tee. So it's kind of the same with your shoulder joint, having a shallow socket, greater range of motion, but obviously you're going to sacrifice stability for that. There are some reinforcing ligaments around the shoulder joint. One of the things that you'll see in the lab PDF this week for chapter 8 is you will see the shoulder joint. Now these reinforcing ligaments that we find in the shoulder joint, they are all named for bone markings. So that makes it pretty easy. They seem really complicated, but again, they're just named for all your bone markings. So there's a coracohumeral ligament. So this is going to run from the coracoid process to the humerus. This is basically supporting the weight of the upper arm. There's also a glenohumeral ligament, which is running from the glenoid cavity to the humerus. And this is going to help to strengthen kind of the front of that shoulder joint. Now, there are a lot of muscle tendons that help with joint stability because remember, nice, tight, tone muscles equal tight tendons. This is the #1 thing that helps with joint stability, right? So a lot of the muscle tendons that you have that span across your shoulder joint really help with stability of the joint. So we call these our rotator cuffs, are the subscapularis. Now I know that we have not done muscles yet, but muscles, a lot of the muscles that are in your shoulder are named also after bone markings. So the subscapularis muscle is a muscle that sits in the subscapular fossa. The supraspinatus muscle sits in the supraspinous fossa. The infraspinatus muscle sits in the infraspinous fossa. And then you also have a teres minor, which is not named after a bone marking. Okay, so those are your 4 rotator cuff muscles. And if those are nice and tight, then your shoulder obviously is going to be more stable. We can stretch these tendons, especially if the arm is vigorously circumducted. Remember, circumduction is like this. It's a cone in space. So pitchers, baseball pitchers, it is not uncommon for them to tear their rotator cuff and some of those muscles in there, those tendons, because of the way they throw, right? So softball players, baseball players, okay? It can really take a toll on that shoulder joint. So here are some of the ligaments that we can find in the shoulder joint. And I am just going to walk you through some of these. You have to label these for your lab this week. So what we're looking at here, you can see the scapula here. Oops, let me go back here. And you can see the humerus kind of sticking out down here. And so right here, this is our coracoid process on the scapula, and the one back here, this is the acromion or the acromion process on the scapula. So you can see a ligament that runs between the two called the coracoacromial ligament. Again, they're just named for the bone markings. You have this one here, which I already mentioned. This is called the coracohumeral ligament. So you can see it's running from that coracoid process to the humerus. And then we also have this one over here, which is the glenohumeral ligament, which is running from this glenoid cavity, which is right in here, over to the humerus. Now, another thing that you can see here is you can see a lot of the bursa. Now, remember, we find bursa in a lot of our synovial joints. They are little marbles. They're filled with synovial fluid. They help to reduce friction. And so you can see a bursa here. You can see another one right here. Okay. So those are just a few of those ligaments that we might find in the shoulder. Now I'm also going to walk you through, we're going to kind of move on down and let's walk through the hip joint as well. So the hip joint is a ball and socket joint, but it is a much more stable ball and socket. So it's not as shallow as what we find in the shoulder joint. But because of that, that means that you're not going to get as much range of motion out of the hip joint. It's more stable, but you're going to have less motion. Okay, you've got stronger ligaments, you've got a deeper socket in there, so it is more stable. And that's because you're bearing more weight on that joint. There is something called the acetabular, oops, not sure what's happening with my pen. There is something called the acetabular labrum. And essentially, this basically just enhances the depth of the socket. And it kind of, if you think of your acetabulum, the labrum kind of goes around the acetabulum. And it just makes that socket deeper and even more stable. And so it makes dislocating the hip very rare because you just now have this super stable, super deep socket. A couple of ligaments that we find. We have an iliofemoral ligament that runs from the ilium to the femur, a pubofemoral ligament running from the pubis bone to the femur, and an ischiofemoral ligament running from the ischium to the femur. And the way that these run from all those pelvic bones to the femur, they sort of twist on their way down. And so what we say when we look at it, I'll show you a picture, it almost looks like they're screwing the head of that femur into the acetabulum. So again, it's just making it even more stable. So here's an image of that. So I'm just going to show you this picture down here on the bottom right. So you can see these ligaments that are running from those different pelvic bones. And you can see how they sort of rotate as they get down towards the head of the femur. And you can see them here really well. Okay. And so those are basically increasing the stability of that joint, right? And then up here, the top right. So one of the things that I want to point out up here, well, a few of the things that I want to point out up here is one, you can see this articular capsule right here. They've cut it and moved it away. But that would normally sit all the way around this acetabulum right here. So again, making that socket deeper. You see the head of the femur, and you can actually see it's really shiny here. So this is that hyaline cartilage that's just helping to reduce friction. And then you can also see there are ligaments that are actually going to be connecting the head of the femur into the acetabulum. So again, it makes dislocations pretty rare. Also, the fact that you have really strong muscles in your legs means that the muscles are strong, they're nice and tight, they're toned, the tendons are toned, more stability. Okay, so it's a very stable joint. I think joints. So again, all of these ones we're talking about are synovial joints. The knee joint is the biggest, most complex joint that we have in the body. And the reason why it's complex is because of the way the bones sit together. It's actually sort of like three joints in one. It's not just one joint there. And so I'm going to walk you through. Let me show you a picture. Let's see if I can do it. I don't have the best picture, but we'll use this one here just to describe the three joints. And so if y'all remember from our bone markings, right? So you can see the femur and then you can see the tibia. Those are what are bearing the most weight, right? Femur is the biggest bone in the body. Tibia is the second strongest bone in the body. And so remember, on the femur, we have a medial condyle, and on the tibia, we have a medial condyle. On the femur, we have a lateral condyle, and on the tibia, we have a lateral condyle. Those are coming in contact with each other. So we actually say over here on the medial side that that would make up one joint because that's where the bones are coming together. And on the lateral side, that's making up a separate joint. And then the third joint that makes up the knee is here. It's actually between the patella and the femur, okay? So those are kind of the three joints that we're finding within the knee joint, okay? So we say we have a femoropatellar joint, and then we have a lateral and a medial tibiofemoral joint, okay? And the knee allows obviously for flexion and extension, and there's a little bit of lateral rotation in there, not much, but a little bit. If you look at the knee joint from the side, you can already see just how complicated this joint is. There are lots of bursa in the knee, reducing frictions. You can see them here and down here and even up here above the patella. You can see the fatty pads, right? This orange right here is a fatty pad. That's just helping with protection and absorbing shock. Then you can also see a lot of ligaments and reinforcing ligaments that we might find. You can also see part of a meniscus here. That's that cartilage pad between the femur and the tibia. So this already kind of gets into the complicated structure of the knee. Now I'm going to walk you through just kind of what we find in the front of a knee joint. So in the anterior knee, you can see there are a lot of ligaments here. Ligaments and tendons. So let me see if I can erase what I just, no. I don't know why I can't erase, but I can't erase. I just changed the color of my pen, but I can't erase it. I think I'm using just the wrong tools. Okay, well I can't erase. But if we look at the front of the knee, you can see here, this muscle up here, this is our quadricep muscle at the very top. And so we have a tendon of the quadricep muscle. So this is we call this right here, the quadricep tendon, okay? We also have below the patella, we have something called a patellar ligament, which is right here. So notice those are two different names, right? Quadricep tendon, patellar ligament. I want you to think about the difference between a tendon and a ligament. A tendon connects muscle to bone, okay? So we've got connecting the quadricep muscle down to the patella bone, okay? Quadricep tendon. A ligament connects bone to bone. So we call this the patellar ligament because it's running from the patella down to the tibia, bone to bone, right? So that's two that we'll find in the front. We also have the lateral and medial patellar retinacula. And these are right here. Okay, so you can see that's the lateral. We know it's lateral because here's our fibula. Fibula is always lateral. Here's our medial patellar retinaculum. And then we also have our fibular and tibial collateral ligaments. You'll see these in the lab this week. So the collateral ligaments are on the very outside. Now this is not everything in the front of the knee. This is just some of the front, the anterior structures, but you can see right here, we've already got 6 different ligaments and tendons that are running and supporting the front of the knee. Now we're gonna look at the back of the knee. That looks like a hot mess. You do not have to know on the back of the knee every single one of these structures, but what I want you to know is that in the back of the knee, you've got tendons and ligaments running up and down, right and left, diagonal, all over the place to really help to reinforce and stabilize the back, the posterior knee joint. And this is going to prevent undesired motion like hyperextension. You do not want your knee to hyperextend. Okay, so all of these really help to stabilize the back of the knee. Again, remember, nice tight toned muscles are the #1 thing that helps to stabilize your joint. So a lot of these that you're looking at, if you'll notice, a lot of these are tendons. So the tighter the muscle, the tighter the tendon, okay, more stable the joint. Now, a couple other structures that we find that support the knee joint are things like your cruciate ligaments. The term cruciate means cross, means X. These are intracapsular ligaments. We talked about that at the beginning of chapter 8. That means that they're inside that synovial capsule and they cross each other. So these are, you have an anterior and a posterior cruciate. These are really going to help the femur and the tibia sit on top of each other and prevent the femur from sliding forward or backward off the tibia. It just kind of holds them in alignment. So in this image, we can see that really well, right? So we can see here, this is our anterior cruciate, and the one in the back, you can see it crosses behind. That's our posterior cruciate. Again, these are intracapsular, so they're inside that synovial capsule, okay? Some other things that we have are the menisci. So we have a medial and a lateral meniscus. This is basically a little pad of cartilage. They look, we call them semi-lunar. They look like little half-moon structures. So you can see lateral meniscus. Again, we know it's lateral because there's our fibula, and a medial meniscus. And these really help to improve the fit between the femur and the tibia. They prevent the two bones from rocking side to side, really make sure they're nice and stable. Now, because your knee is a really complicated joint, it is very vulnerable. It is particularly vulnerable to a horizontal, or what we call a lateral blow. So being hit from the outside on the knee, that can do the most damage to the knee joint. And so we say the most common injuries to the knee are to the 3 C's: the collateral ligaments, the cruciate ligaments, and the cartilage. So let me show you pictures of these just to remind you of what they are, okay? So remember the collateral ligaments, these run along the very outside, okay? So this one is the fibular collateral ligament, and this is the tibial collateral ligament here, you can see is torn. The meniscus of the knee, that's our cartilage, so you can see the meniscus here and here, that's already torn. And then you can also see your cruciate, or yeah, the cruciate ligaments. So you can see that anterior cruciate is torn here. And so in this picture, you know, this is showing a hockey puck hitting the side of the knee. My son plays hockey, and you know, at 8 years old, they don't, you know, they can hit the puck hard, but not that hard. But boy, when some of the coaches and the adults get on there and play, they hit that puck so hard. It's insane. And I think, man, if someone were actually hit with that, it would do some damage. And so this is showing if it hits the outside of the knee, right, the lateral side of the knee, you can see that the way that the knee is going to bend, it's going to tear the collateral ligament, it's going to tear the meniscus, and it's going to tear that cruciate, the anterior cruciate ligament. And so it's not just from a lateral blow that can cause these problems, but also direction changes. So, you know, if you pivot really fast, so think like soccer player, football player, lacrosse players. If you're running and you quickly change directions, that can cause the same kind of injuries. Now, the ACL, which is this one right here, this one's going to heal very slowly. They all heal slowly, but this one heals very slowly. There's no blood supply, basically. So if you completely tear that, it typically requires surgery. Usually they can do laparoscopic surgery. I'm going to walk you through, you know, we've kind of touched on this already. We've kind of started talking about some joint injuries. So I'm going to keep talking about some joint injuries. We've done the major joints of the body that I wanted to hit on. So there's really just those 4: the jaw, the shoulder, the hip, and the knee. Again, most of these you're also labeling for your lab this week. Some of the joint injuries that we see are things like a sprain. You know, I'm sure a lot of you have sprained something before. A cartilage injury like damaging the meniscus in the knee, or even a dislocation. So a sprain, let's talk about what that is. If your joint moves in an undesired motion, it can cause the ligaments that reinforce that joint to stretch or to even tear. And so a sprain is basically if you get an undesired motion and you stretch or tear those ligaments. A lot of times what we'll find accompanying a sprain is you're not going to be able to move your joint. It's going to get really swollen and painful. That's obviously going to help you not move it. A lot of times it might bruise, it might turn black and blue. Remember, if you tear a ligament, it heals very slowly because it has no blood supply. If you partially tear a ligament, it will heal. It just takes a long time to heal. If you completely tear a ligament, you're gonna have to have surgery. You know, I think I mentioned last week or on Monday, completely torn ligaments, surgeons say it's like trying to sew two ends of a bristle hairbrush together. So it's super complicated work. Another injury would be damaging the cartilage, like the meniscus in the knee. Sometimes we call these snap and pop injuries, and that's because when you damage the cartilage, again, think of cartilage as that really tough, slick stuff. And so we can see here, torn, okay? And where it's torn, it bubbles up like it, I mean, you can see it right here, right? It looks kind of bubbled up. It's not nice and smooth anymore. That's going to be painful. So every time you move that joint, it's going to be super painful. And you're going to probably hear it. You'll hear the creaking and the snapping and the popping when you move that joint. These are really common aerobics injuries. So doing any kind of aerobic activity can lead to a torn meniscus. A lot of times they'll repair this with surgery. They'll do orthoscopic surgery where they'll kind of go in and just sort of shave off that portion of the cartilage that's bubbled up so it's no longer hurting as you move the joint. Problem is, remember, that cartilage improves the fit between the two bones. So if you have to shave some of it down, now the joint is going to be less stable. You have made the fit less than ideal between those two bones. And then the last kind of joint injury I'll mention are dislocations. This is anytime the bone actually comes out of alignment. So if we're looking at like a ball and socket, if that ball and socket come out of alignment. Obviously, if you dislocate your joint, if you completely remove those two articulating bones from each other, it's going to be accompanied with a sprain. So you have either stretched or torn your ligaments. There's going to be a lot of swelling, and you're not going to be able to move the joint if the bones are not articulating together anymore. This is typically caused by a fall or a sports injury. My father-in-law, they got like a new refrigerator, and it had a door ice maker, and it was leaking, and he didn't know. And he came in and stepped on a puddle of water that he didn't see and slipped. His feet went out from under him, and he tried to catch himself by grabbing onto the cabinets, the upper cabinets. And so when he fell, all of his weight went into his shoulder joint, and it completely pulled his shoulder out of socket. So it's completely dislocated. And when he went to the emergency room, they popped it back into place, and they put him in a sling and sent him home. They didn't do any kind of soft tissue imaging, so no MRIs, nothing. And it ended up where he was in this sling for like 6 weeks, and then the sling came off, and he had to do physical therapy for like 6 or 12 weeks, and he was not getting better. It was still very painful. He did not have a good range of motion. And the physical therapist towards the end was like, you know, I'm not sure that you don't have some soft tissue damage in there. And so at this point, it had been like 12 or 15 weeks since the original accident. And he went in, had an image done of his shoulder, and they didn't catch it. And so now he had to go have surgery. But at this point, 15 weeks later, he had tons of scar tissue in there. They said it was a very complicated surgery because of all the scar tissue and how long it had been. So the moral of that story is that if you ever dislocate something, make sure that they do an image and make sure that you know if anything has been torn ahead of time, because you may need surgery, and the sooner you have it, the better your chances of recovery will be. This term down here is subluxation. This is when you partially dislocate a joint. So it's almost like the joint comes out of socket, and as you move it, it pops itself right back into place. This one, it still can be accompanied with sprains. You don't typically have to go to the emergency room, but it is going to be painful. Anytime you dislocate or even subluxate a joint, repeat dislocations are going to be super common because you have now damaged those ligaments. You stretched them. Remember, ligaments aren't stretchy. They only stretch about 6% before they tear. So if you've dislocated or subluxated any joint in the body, now those ligaments are stretched out and the joint is going to be much less stable than it was before. So repeat dislocations, very common. All right, so the last part of this chapter focuses on a couple of degenerative conditions or inflammatory conditions that we see. Some of these I've touched on, like bursitis and tendonitis, and some I have not. So we're going to walk through these. Hang on, I'm going to try to clear off those black marks. They're driving me nuts. There we go. So let's walk through first, let's walk through bursitis and tendonitis, right? So we've talked about a bursa and a tendon sheath. So bursitis, remember itis means inflammation of, right? Inflammation of the bursa. Those little marbles in there that are supposed to reduce friction. If they're swollen, they're not doing their job. So moving that joint becomes very painful. These are typically treated with anti-inflammatory drugs. Sometimes they may have to go in and aspirate some of the fluid off of that joint and out of that bursa to get the swelling down. This is really common. I'm going to skip back to the picture of the knee, the lateral view right here. This is really common in the knee joint where people can develop bursitis. Sometimes we even call it water on the knee. So you have a really big bursa here and you have another one here. So you have one above and below the patella. And these, a lot of times, if they get swollen, they have to aspirate some of that fluid. That's why we call it water on the knee. Your knees a lot. So if you kneel a lot, if you are a gardener or if you're a house cleaner and you're cleaning floors and toilets and bathrooms and stuff like that, it can lead to problems with the bursa. And then we also have tendonitis. Tendonitis is very similar to bursitis. It is just swelling of the tendon sheath. Remember, a tendon sheath is like a bursa that wraps all the way around a tendon. The symptoms are really similar. You're going to have pain when you move your joint, and the treatment is really similar to bursitis. You just need to take some anti-inflammatories. A lot of times, like NSAIDs or steroids can help reduce inflammation. Sometimes they may have to aspirate the excess fluid. Okay. Now, I also want to walk you through arthritis. Now, there's a lot of different kinds of arthritis. There's actually more than 100 different types of arthritis. We are just going to walk through two different ones that are, one is the most common type of arthritis. Another one is very different. So we'll talk about that one. This is actually one of the most widespread crippling diseases of the US. And the symptoms of arthritis is just pain in the joint. Sometimes the joint gets really stiff. It's very painful to move. Sometimes the joint will be swollen. Now, there's actually, we classify all these different forms of arthritis two ways. One is acute. Acute just means sudden onset. This is typically caused by bacteria, and so the treatment of this is easy, antibiotics. I'm not going to really touch on that kind of arthritis. The other kind is chronic arthritis, and chronic just means long-lasting. And the two forms that I'm going to talk about are osteoarthritis and rheumatoid arthritis. Now, these are not the only two forms of chronic arthritis, but one is very common and the other one is just very different. So the first one, osteoarthritis. Well, we know osteo means bone and arthro means joint, right? So this is the most common form of arthritis. And a lot of times it's actually because it's so common, we call it wear and tear arthritis. It does affect more women than men. We don't know why. Actually, a lot of the joint diseases that we see affect more women than men. your book says about 85% of all Americans develop osteoarthritis at some point in their life. I think most doctors would say that 100% of people develop osteoarthritis to varying degrees. And so, you know, a lot of surgeons and a lot of doctors basically just say that this is just part of the natural aging process of your joints, is that they're going to get stiff and they're going to get painful as you age. Obviously, it is more prevalent in the elderly. We call it wear and tear arthritis for a reason. As you get older, as you use your joints, you're going to break them down. So let's talk about what happens in this course of osteoarthritis, like what's happening in the joint. So under normal use, when you work out, if you walk, if you run, whatever you do, you naturally are going to break the joint down. Just the wear and tear of those bones rubbing on each other, you're breaking that joint down a little bit. But you're also going to replace it as fast as you break it down. So normally, especially the cartilage pads, like think of the meniscus of the knee. If you walk, if you run, your body will naturally break that cartilage down and build it back up at the same rate. But as you get older, you're going to break it down faster than you build it back up. So the cartilage pad over time is going to get thinner and thinner and thinner as you age. And it actually will eventually cause the ends of the bones that articulate with each other to get thicker. Sometimes they might form bony spurs, and it's going to cause movement to be painful, so it may restrict your movement. Joints that are most affected by osteoarthritis are the spine, so the cervical and the lumbar vertebrae, your fingers and your knuckles, your knees and your hips, right? So these are, all of these are synovial joints. They all are freely movable joints, and so osteoarthritis really affects those joints that you're moving a lot. So the symptoms of osteoarthritis are things like stiffness in the joint and something called crepitus, which is noise. It's sort of a creaking noise. So if you have it in your fingers and you bend your fingers, you might hear this sort of creaking, squeaking sound coming from those joints. Now, osteoarthritis is slow, it's irreversible. The treatments of this basically just take some pain relievers, take Tylenol, take Aleve, take Advil, but keep moving your joints. The best thing we can do for our joints is to continue to move them, but do it in a way that you are not putting a ton of pressure on the joint. So honestly, one of the best exercises you can do is swimming, or a stationary bike, doing something where you're moving your joints, but you don't have a ton of pressure and wear and tear on the joint. That's super helpful. One thing that I think is pretty interesting is there are some supplements like glucosamine and chondroitin sulfate that have been shown to actually decrease not only pain, but inflammation in the joint as well, and preserve the cartilage, that articular cartilage that wraps around your bones. And so, one thing that I think is really fascinating is that a lot of times, whatever we do in human medicine, a lot of times for vet medicine, we can take what we know about humans and a lot of times apply it to other animals. So I had a student once tell me that they had horses and she did dressage, which is like the horses that jump over those white picket fencey things. Y'all, I'm sure you know what I'm talking about. I'm not a horse person, so I'm sorry if you are. But she said for those horses that did dressage, that did the jumping, she said their feed is actually supplemented with glucosamine and chondroitin sulfate for their joints. And I thought that was pretty interesting. Another kind of arthritis, now this one is totally different, is rheumatoid arthritis. So I'm going to ask you questions about these two forms of arthritis. Make sure that you understand osteoarthritis is a natural aging process of the joint. You just break it down faster than you build it back up, okay? Rheumatoid arthritis, this is very different. Rheumatoid arthritis is an autoimmune disease. Auto means self, So an autoimmune disease is when your immune system, which should attack something foreign that gets into your body, starts attacking yourself. It starts attacking your own body tissues. So rheumatoid arthritis is an autoimmune disease. We don't know what causes it. It is chronic, so it's long lasting. You're never going to get rid of it once you've been diagnosed with it. Usually you'll be diagnosed between the ages of about 40 and 50, but you can be diagnosed at any age. I've had students diagnosed as early as 11 years old. I had a student who had it in her elbows. It affects 3 times more women than men, as with most of these forms of arthritis. So I'm going to walk you through the course of rheumatoid arthritis. Again, very different from osteoarthritis. So rheumatoid arthritis, because it's an autoimmune disease, this one is going to start with inflammation of the joint. So maybe you have worked out and your joint becomes a little swollen. Inflammation is actually part of, it's an immune response. And so because rheumatoid arthritis is an autoimmune disease, this is actually what's going to trigger the problem. So what happens is you use your joint, it becomes a little swollen, and someone with rheumatoid arthritis will release not just a few inflammatory chemicals, which are normal, they'll release inflammatory chemicals in huge amounts. This is actually going to cause tissues to start to degrade. So in anatomy, and hopefully y'all have realized this, anything dealing with the body, too little of something is bad and too much of something is bad. You want just the right amount. So too many inflammatory chemicals is very dangerous and it can destroy your tissues. It actually will cause synovial fluid to start accumulating in the joint, which causes even more swelling, which causes more inflammatory chemicals. Eventually the synovial membrane that surrounds that joint and holds the fluid in there will start to get really thick and it'll start to cling to the bone and the cartilage. You'll start to form some scar tissue and it causes the ends of those articulating bones to connect and they can fuse together. And if they fuse together, the joint becomes immobile. We call this ankylosis. So here is, I'll show you an image. Here's an image of ankylosis in the fingers. And so you can see that those joints obviously have fused together. This person has no range of motion in those in their hands. Typically the signs and symptoms of rheumatoid arthritis. A lot of times your joints are affected bilateral. Bi means 2. So this means both sides. So let's say your right elbow is affected, so is your left elbow. Right hand, so is your left hand. Okay, not always, but a lot of times. The joints are very tender, and it can also lead to a lot of other issues, right? If your joints hurt, and if using the joint causes more pain, you're going to be really hesitant to use your joint. So if you're not using your joints, that probably means you're not working out, right? So cardiovascular problems are huge in people with RA. If you're not working out, your muscles are atrophying. If you're not working out, so remember we talked about in chapter 6 how your bones remodel, how you'll lay down more bone based on the demands and the stress you put on your bone. Well, if you're not working out and you're not lifting weights, you're not laying down new bone. So your bones start to get very weak and brittle. So osteoporosis will set in. So all of these issues sort of snowball when it comes to rheumatoid arthritis. Unfortunately, with rheumatoid arthritis, a lot of times there's exacerbations where it gets worse, and then there's remissions where you actually start to feel a little bit better. The therapy for rheumatoid arthritis, usually it's kind of conservative therapy. So a lot of times they might suggest just aspirin. Sometimes you might take antibiotics. Sometimes just doing some physical therapy, wearing a weighted harness can help. But then there's also more progressive treatments. These are going to be things like taking anti-inflammatory drugs. Anti-inflammatory drugs will keep the swelling down. It'll keep you from releasing those inflammatory chemicals. But a lot of anti-inflammatory drugs are like things like steroids. And we know that steroids can really damage your kidneys, your liver. And so doctors really have to weigh the benefit of you taking something like a steroid long term versus the risks associated with that. They can also put you on immunosuppressants. Since this is an autoimmune disease, they can say, hey, take some immunosuppressants, we'll turn your immune system off so it doesn't attack yourself. But that also means that it's not going to attack something foreign, so you have a greater chance of getting sick. There are some other drugs, things like Enbrel. Enbrel is what we call a biological response modifier. So this is a drug that you take that actually neutralizes those inflammatory chemicals so that they're not so harmful in large amounts. So this is another one that can be really helpful for people. All right, so those are the forms of arthritis. The last type of degenerative condition that I want to mention is Lyme disease. I'm sure y'all have heard of Lyme disease before. Lyme disease is actually caused by a spirochete bacteria that is carried and transmitted by ticks. So if you are bitten by a tick that is carrying this bacteria, then the bacteria can get into your body. If it is not treated and that bacteria is allowed to grow in your body, it can result in neurological disorders. So the symptoms are things like joint pain and arthritis. There is a very indicative skin rash I'll show you a picture of if you are bitten by a tick that carries this bacteria. And then otherwise, it's very, very much like flu-like symptoms. So you're tired and achy, muscle aches. You might have a fever. So here is the rash. So this is we call this a bullseye rash. If you are bitten by a tick that is carrying the spirochete bacteria, you'll see this type of rash that will form. A lot of times though, ticks, they might bite you in places that you can't see the rash, like somewhere in your scalp where you have hair, you may not be able to see this rash. I will typically, if my son has a tick on him, my family has a cabin in the woods, and so if we go there, there's tons of deer, tons of ticks. If we ever pull a tick off of somebody, wherever we've pulled the tick off, we'll take a Sharpie marker and just put a little dot right where that tick was. And that way for the next couple of days, we can monitor that area and just make sure we don't see a little bullseye rash. The treatment of this is super simple. It's really just antibiotics, right? Because this is caused by a bacteria, antibiotics. Unfortunately, what happens though is that people don't realize that they've been bitten by a tick that has this bacteria in it until it's too late and it's spread to their nervous system to check for that bullseye rash. There is a vaccine that's approved by the USDA. The people who usually take this vaccine are people who are around environments where there are a lot of ticks. So, foresters, or, people who cut down trees for a living, or, people who are in wildlife biology, they might be good candidates for this. But if you just go camping like 3 times a year, you probably don't need the vaccine. So the picture on the bottom left, this is actually a picture of a tick here. And this is a tick that is engorged and fed on a blood meal. So it looks very different. They almost look like a piece of gray bubble gum. They look really weird. All right. In terms of your joints, the very last thing I'm going to walk you through is just the development of joints. So the skeleton starts forming around the 7th week of gestation. Around week 8, your joints will resemble adult joints. And you usually don't have any problems with your joints until you get older. Again, as you age, your ligaments and your tendons get shorter, they get weaker, your muscles get weaker, so your joints become less stable. Intervertebral discs are more likely to herniate as you age, so you might have the back pain or that sharp shooting pain down your arms and legs. Again, most people over the age of 70 have some form of osteoarthritis. Again, this is just part of the natural aging process of your joints. Doctors are actually seeing arthritis in younger and younger people. And the two most common places that they're seeing it, there's two places. One is in the cervical spine, and that's because, I have my phone here, so I'll do this. That's because people do this. They look down at their phone like this, and their head is hanging. Your head is heavy. And it's not meant to go like this. And so that's a lot of extra pressure on that cervical region of your spine. So they're seeing some osteoarthritis developing here in younger people. And the other place is right here in that saddle joint of the thumb. And that is from scrolling on your phone, doing this all the time. So it's just overuse of these joints. Prevention and maintenance. You know, making sure that you're moving your joints through their full range of motion is a great thing. So swimming is fabulous for your joints. Keep them going through a full range of motion so that you don't have these joint problems, and try to keep the pressure off your joints. Okay. All right. Does anybody have any questions on chapter 8?